Hello and welcome to Perspectives on PH. I'm Thomas Baldrick. PAH.TV brings you up-to-date coverage on some of the latest abstracts presented at the 2013 American Thoracic Society International Conference. For all the related abstracts presented in PH, please visit the ATS website. We're now pleased to welcome Dr. Erika Rosenzweig, Medical Director of the Pulmonary Hypertension Center at Columbia University in New York. Dr. Rosenzweig will highlight key abstracts presented during ATS that are especially relevant to pediatric patients with PAH. Welcome, Dr. Rosenzweig.
Thanks, Tom. Today I'm going to discuss a couple of important abstracts that relate to pediatric PAH that were presented at this year's American Thoracic Society meetings. And the first one I'm going to talk about relates to outcomes of pulmonary hypertension in childhood. And this data was reported from a global top registry, which is a pediatric pulmonary hypertension registry. The top registry is not only global, but a prospective pediatric observational registry for childhood pulmonary hypertension. And in this registry, which is really one of the first of its kind, the patients underwent clinical assessments and received their standard medical care, which was determined by their primary PH treating physicians. There were 568 consecutive patients enrolled under the age of 18 years or at 18 years of age, and this was in 34 centers in 20 different countries. Of those 568 patients, 494 patients actually qualified as having pulmonary arterial hypertension. Of these 494 patients, there were 188 incident patients, meaning that the time since their diagnosis was just less than 3 months. And this becomes important in the analysis. So the objective of this study was to describe survival, that is time from diagnosis to death, and the candidate risk factors in incident pediatric PAH patients, again, those patients who had been recently diagnosed. The investigators found that the median time to follow-up in these data were 2.4 years for all patients and 1.4 years for the incident patients. Specifically, of all patients, 14% had a fatal event, and of those incident patients, 18% had a fatal event. So the death rate was 6.8 per 100 person years for all patients and 11.2 per 100 person years for the incident patients. And the authors specifically wanted to look, again, at the incident patients to find risk factors that increase the hazard of death in these patients. And what you can see in this slide is that age at diagnosis, WHO functional class, NT-proBNP, height for age Z-score, mean right atrial pressure, and systemic venous saturation all came out as significant risk factors for death in incident pediatric PAH patients.
What is the most critical finding in the top registry, and how will it impact your care of children with PAH?
So these findings really are important not only because they represent a global perspective on pediatric PAH and a registry, again, which is the first of its kind, but a global perspective on the risk factors for children who have pulmonary arterial hypertension. And it also appears that similar to adults, these incident cases seem to fare worse than the prevalent cases of pulmonary arterial hypertension. So I'm going to move on to the next abstract that we thought was important on pediatric pulmonary hypertension. And this was entitled Effects of Oral Sildenafil Treatment on Exercise Capacity in Children with Pulmonary Arterial Hypertension. And this was presented by Dr. Ranu Dees and was a study to look at extension data from the previous STARTS-1 study and exercise tolerance. So as a background, in the original STARTS-1 study, children aged 1 to 17 years over 8 kilos or equaling 8 kilograms in weight were randomized and stratified by weight and ability to exercise to low, medium, or high dose sildenafil orally given 3 times a day versus placebo for 16 weeks. The patients in this particular abstract that were reported on were those enrolled in STARTS-2, which again was an extension of the STARTS-1 trial, and these patients were maintained on the sildenafil dose that they had received in the previous STARTS-1 trial, either low, medium, or high, whereas the placebo patients who were treated in STARTS-1 with placebo were then randomly assigned, and again stratified by weight, to one of 3 sildenafil doses. There were 234 children in total randomized and treated in the STARTS-1 study, and of these 234 children, 115 could exercise reliably and perform a cycloergometry cardiopulmonary exercise test. So these were the children that were included in this analysis. The STARTS-2 extension study looked at the long-term effects of sildenafil treatment in children on exercise as measured by peak VO2 at a year follow-up. These children underwent CPET, or cardiopulmonary exercise testing, at baseline, 16 weeks, and the 1-year follow-up, and these data were analyzed. Just to review from the STARTS-1 data, at week 16, the pre-specified primary endpoint, which was the mean change in peak VO2, or oxygen consumption, increase for all 3 sildenafil groups was combined, and that was pre-specified, and the improvement was 7.7%, which just missed being statistically significant. The change at peak VO2 at 16 weeks actually was higher for the medium and high-dose sildenafil groups and than it was in the low-dose groups. Interestingly, though, in the STARTS-2 study, at 1 year, the reverse was true, and only the pediatric patients in the low-dose sildenafil group had a significant increase in the peak VO2 of 11.3%, and the p-value was 0.15. This is illustrated on the next slide in this graphic, and again, a reverse association was seen at 1 year when compared to 16-week follow-up on sildenafil.
What is the most important takeaway point from the STARTS-1 study?
So this finding appears to be very important, particularly with the recent FDA warning against the use of sildenafil in children with PAH ages 1 to 17 years. While in the original START-1 study, the use of low-dose sildenafil was safe, but not thought to be effective as it didn't reach statistically significant improvement in peak VO2, these data suggest that longer-term use, out to 1-year follow-up, may actually provide an exercise benefit for children in the low-dose group with pulmonary arterial hypertension.
Thank you, Dr. Rosenzweig, for this insightful analysis. That's Dr. Erika Rosenzweig from Columbia University. Thank you to all of the experts who contributed to this edition of Perspectives on PH. We look forward to seeing you here at PAH.TV as we cover the latest news in pulmonary hypertension.